I'm going to introduce our next speakers. We have Dr. Bloom and Dr. Law, who will be speaking on pediatric migraines. Dr. Bloom received her medical degree from Harvard Medical School and her master in public health from University of Washington. She is a child neurologist and the director and founder of the Headache program at Seattle Children's. She's been on staff at Seattle Children's in the neurology division since 2003. And Dr. Bloom's interests include migraine management and post-traumatic headaches. She also has interests in headache disorders, including hemiplegic migraine. And then Dr. Law is a pediatric psychologist and associate professor in the Department of Anesthesiology and Pain Medicine at UW. Dr. Law provides clinical service in the multidisciplinary headache clinic at Seattle Children's and leads the NIH-funded research studies that aim to improve the lives of youth with chronic headache and other chronic pain conditions through innovative technology-driven solutions to provide access to evidence-based behavioral pain treatment. She received a PhD in clinical psychology from the University of Maryland in Baltimore County and completed her pre-doctoral internship in pediatric child clinical psychology at UCLA. Her research is funded by the National Institutes of Health and National Institute of Neurologic Disorders and Stroke, and it focuses on improving the lives of youth with chronic headache through the development and evaluation of technology-delivered psychosocial risk screening and behavioral pain management treatment. And Dr. Law has also co-authored a self-help book for parents of children with chronic pain titled Managing Your Child's Chronic Pain.
So thanks for having us to talk about a little bit about pediatric migraine, and we're trying to focus on issues that you may come up with in school or in the clinic that are somewhat practical, and how to create a better environment for these kids and help to decrease their disability and get them doing all the things they want to do. Overall, I'm just going to talk a little bit about red flags for secondary headache, like what things you would not want to miss, and to make sure that kid does get the appropriate workup and seen in neurology, and talk a little bit about pediatric migraine, what the basics are, what medicines you may expect to see in school or in clinic, and then hopefully have a little time to talk about some of the new treatments that are out there. Of note, there are really not a lot of data on these for pediatrics yet, but we are starting to use some of those things in practice. And then Dr. Law is a pain psychologist that I get to work with once a week on some of our more complex patients. And she's going to talk about some of the issues at school and school resources and stigma around migraine. I just put this quote up here because it's pretty much what we hear almost all the time with many of our patients, that the families and the patient don't want to just treat the pain. They want to figure out what's causing it and give them more medications. But oftentimes it's really hard to find. Most of the time with migraine or other primary headache disorders, the scans, the labs, all that are going to be normal because it's a genetic disorder that's got a lot of different reasons that the headaches, that can trigger headaches and can make headaches worse. So working with families to let them know that that's what's going on is important. This is a chart I use a lot, and it's a kind of a nice illustration of all the different headache types in one spot. So the episodic recurrent headaches in blue here are the ones that are like migraine or possibly more significant tension type headaches. The one in red is the one that you really want to, those are the kids who need a workup, likely need imaging, where the headache started and it's just getting worse and worse and worse and worse, and it's causing disability and it's causing problems. So those are the kids that really need an evaluation. The new daily persistent headaches in purple, those kids will also get an evaluation to make sure there's no secondary causes. But often this is another type of primary headache disorder that we end up managing. And then the chronic non-progressive types are the kids who may have had episodic migraines that kind of come and go, but they've been the same for many years, and they're most likely a primary headache disorder. What's tough sometimes is this green line, because that's an acute headache, and you don't know, is that going to go on to keep getting worse or is it going to get better? But there are definitely times when time is reasonably on your side, so you can just monitor them, see them back in a few days or a few weeks, and have the family call you if there's new symptoms or problems. And this is a mnemonic for the things to worry about or when to worry about a secondary cause of headache, because there are many, many, many different causes of headache. So this is SNOOPY, adapted from the adult mnemonic that was just plain Snoop. But S is for systemic symptoms or signs. So if there's fever, if they're immunosuppressed, if they have lupus, they have a sickle cell or at risk for stroke or thrombosis. I mean, those are the kids when you really need to look for a secondary cause. New neurological signs, that's N. So if they are less coordinated than they used to be, certainly if they have any new weakness or other new neurological problems or asymmetry on neuroexam, those kids need to be seen. Onset, sudden onset is O. O meaning like thunderclap headache. You're probably going to see those kids in clinic. Those little kids will end up in the ER where it's just super sudden. But even a rapid onset of a new type of headache is important to pay attention to. An onset after age 40, we don't have to worry about in peds, so we could just make this SNOOPY, but that doesn't sound very good. P is for lots of different things. Change in the pattern of the headache, papilledema on ophthalmological exam, positional headache, meaning that it's worse when they lay down, or if it's worse in the morning or is waking them from sleep, then we worry about elevated ICP. If it's worse when they stand up, that could be still migraine, or tension type headache, is headaches often are better when you lay down in a dark place, but also could potentially be a CSF leak if they've had a history of trauma or something else. And then pregnancy. And pregnancy is something never to forget. It certainly, I have missed that once in a patient who had abdominal pain and headaches that were getting worse. And she went and got her abdominal ultrasound and she was pregnant, which explains some of the changes in her symptoms. And young age at onset, really there's not a exact cutoff. Like I would image a 3-year-old and not a 4-year-old. But certainly that's one piece of information that you take into account when you're doing a workup. And this is just a short list of some of the different disorders that may cause headaches. It's almost as bad as dizziness, and that there's lots and lots of different things that could cause them. But with a good history and physical, a lot of these things can be evaluated or ruled out. So sometimes if they don't have red flags and I'm not doing imaging, if there's a lot of fatigue or dizziness, I may check a CBC and iron and TSH. If they've got abdominal pain, I may check celiac screen. But it really depends on the clinical situation. But significant headaches are a big problem in pediatrics, that all of you are here at this session, that up to somewhere between 3 and 23% of kids will have headaches and have migraines in particular, especially in the teenage females. Tension type headaches are also relatively common. Chronic daily headaches and chronic migraine are less common, but still 2 to 3%, which means that there's going to be several kids in every school, in every clinic office with chronic migraines who are dealing with potential disability related to migraine. And this is from the American Migraine Foundation, which I'll have later on our list of resources. But 10% or more of children are living their lives with migraine, which can cause missed school, missed opportunities, problems in school and with friends. And this slide I put in mainly kind of to remind us all that migraine is a complex disorder, a complex neuronal disorder. A long time ago, they thought that it was mainly just related to vasoconstriction in the blood vessels in the dura, but we now know that's just one part of the whole cascade that involves the cortex, the thalamus, the brainstem, the trigemico-cervical complex, meaning the nerve roots and nerves from the cervical region connect with the trigeminal nerve and trigeminal nerve nucleus, which is all involved in migraine generation and propagation. These are the busy slides. So is it a migraine or not? Again, migraine definitions that it's a severe, it can be either unilateral on one side or bifrontal in kids. Pulsing quality, they may say it feels like it's drumming or throbbing, and it gets worse when you do something. So I'll ask if it gets worse when they run up the stairs or out in recess. That with either nausea or vomiting or photophobia and phonophobia, but oftentimes folks have both. And you can, if the kid is wanting to go in a dark room and get under the covers and gets irritated at their brother for making noise or turning on the TV, then it's likely to be a migraine. But also at the caveat at the end of all of these definitions, it's not attributed to another disorder because other secondary headaches could have some of these symptoms as well. And here's with aura, I put a picture up here of an example of an aura. So flashing lights or spots or that move, usually not in color, usually black or white or zigzags, or all different types of visual aura, which is the most common type of aura. Next most common is sensory aura, with tingling that can be just on one side or can start on one side and move to the other side. Those are all pretty typical. I don't necessarily do more work if those are the main symptoms and it's really consistent with migraine. But if they do have speech problems, and certainly if they have motor weakness, I will do imaging and may consider either genetic workup for hemiplegic migraine or other things. The aura should start before the headache and go away within 60 minutes. And the chronic migraine means that you're having headaches more than half the days of the month, and at least a quarter of those, at least 8 days, are migraine-like headaches. And as you can imagine, having a bad migraine more than 8 days a month can be pretty disabling. But I put this slide up. I thought that was nice from Cincinnati Children's, developed a really quick migraine screener. So that these are really quick questions you can ask kids in school or in the office to really determine, are these significant, are these likely to be migraines that are causing problems for the kiddo, or are these maybe more like tension type headaches that where maybe a little bit of water or rest is the main thing that needs to be done. So again, is the pain really bad? Does it feel like it's pounding or throbbing? And do you ever skip school or other events because of the headaches? So this is a lot easier than those like 3 really wordy slides and definitions. So what do we do? So it's a really a multifaceted approach with both lifestyle changes, complementary treatments that kids might need, preventive therapies, or abortive medications. And these lifestyle changes are things that anyone can do, any parent can do. At the school, you can also help out with these things. So Dr. Almatine down at Mary Bridge developed a mnemonic SMART, S-M-A-R-T, for sleep, meals and hydration, activity, which means regular, not excessive, and not too much exercise, not too little exercise. And also I put in A for avoid drugs, alcohol, and tobacco. Can all make headaches worse. R for relaxation and avoid stress, manage stress, anxiety, depression, and avoid triggers, or manage triggers at least. In meals, we include regular meals, including breakfast, ideally something with protein so they have fuel to get them through the day. Good hydration for teenagers, we recommend at least 64 ounces of fluid per day, and minimize caffeine use. The other things we can use are biofeedback therapy, which has been found to be probably effective, even when you're looking at some of the more standard definitions of effective or ineffective and data in the guidelines. And then CBT is one of the things that Dr. Law is able to provide. Cognitive behavioral therapy actually is a gold standard for managing chronic headaches, but there are few people who can do this. And so her work on providing electronic online resources is a great boon and work in progress. And I'm sure she'll talk a little bit more about the program and app, web map that you can access for free for any smartphones. Massage therapy, physical therapy, chiropractic therapy, and acupuncture are also options, but there's even less data for these, and the data that is there is a little bit more equivocal. So what anybody can do, and hopefully, I think, if I remember correctly, there's quite a few school nurses and personnel here today. I thought this picture was a nice example of something that someone is able to put up in a sort of a classroom type setting. I know, or that this is not going to be possible in most places, but to provide overall a quiet, dark space where they could rest, drink water, take their medication, whether it's ibuprofen or a Triptan, maybe offer a cool cloth if that's helpful, or a warm cloth if they prefer warmth, and let them rest and try and recover from the headache and migraine in over a few minutes. Many pediatric migraines are shorter than adult migraines, so even 20 or 30 minutes can be a very effective can you get the kids back to school? And also it's important to, even families without a physician involved can develop a migraine action plan. We have formal ones through Seattle Children's Clinic, but you can develop a plan of first letting the child have water and rest, and then ibuprofen at school if they need it. And this is just, again, you all should have copies of these slides, and I put a list of these medicines as well as some of the other medicines in the back. But these are medicines that are going to come up in migraine action plans that are over the counter, and all of these I think are reasonable. Excedrin, migraine, and caffeine. The only issue there is that those we really want kids to use 2 days a week or less, no more than, or 8 days a month, because if you're overusing caffeine, that can cause rebound headaches. There's less data about rebound headaches for the NSAIDs, but it's still not a great idea to take those more than 10 or 15 days per month, because if you're needing that, we really need to get you on some other therapies. The other thing I hope that you guys are familiar with are some of the triptans. I listed some of them here that we use in pediatrics. Axer's been approved for teenagers. Maxalt or rizatriptan's been approved down to age 6. Sumatriptan's been around the longest in a nasal spray and tablets. And all of these have been studied in teenagers and have been safe for most kids. And if the NSAID or the triptan aren't working independently, then using them at the same time at the onset, as soon as they know it's going to be a bad headache, it's really what's important, because they act differently on different parts of the migraine pathway. So that can be very helpful. Oftentimes kids are waiting too long to take these medicines, and so they already have a really bad headache, and it's harder to get that under control. So, and when we want to think about prevention, if there's been more than 4 headache days a month, think about prevention. One of the challenges is that the big NIH-funded randomized control trial found that 2 of the medicines we use most commonly for prevention, amitriptyline and topiramate, really were about equal to placebo in the big trial. So about 60% of kids did have improvement of their headaches, but 60% in all 3 groups. So the study was closed early. But I do think that there are kids who do respond to prescription medications, and there's data to support that as well. So the current guidelines are to just discuss the data and really talk about options. We also will sometimes use supplements initially, and if we're going to optimize that placebo response, I'd rather do that with a supplement than with a prescription medication. You just want to pick a medicine that's going to fit the profile of the child, like avoid beta blockers in someone who's depressed or has asthma, avoid topiramate in somebody who's underweight, but maybe it might be helpful in somebody who's overweight. And you start low and go up slowly. And if there's a lot of nausea, we want to make sure we treat that. And I'll use compazine if there's a lot of, if I'm also trying to treat the migraine as well as the nausea. But hopefully you will not see this in your students or your clinic patients. We really do not recommend, you should not be using opiates, butalbital, Fioricet, Percocet, any of the opiates for headache pain. Over the long run, that will likely lead to worsening pain and headaches. And there is good data for medication overuse headaches for these. And here are some resources. Including the Neurology Patient Education Toolkit. We've got headache logs, handouts about headaches that are, you can Google this, or you can copy the links when you get the slides afterwards. This is the application that Dr. Law has developed with WebMap. It's called WebMap. They can take themselves through this online CBT program. Mouths for Migraine is another one of my new favorite websites. It's got the information as well as online support groups that do video chats, Zoom calls, etc., for both education as well as support. And they even have yoga and cooking classes and all other kinds of things. There's a lot of different resources here through the American Headache Society, Migraine Foundation. Migraines at School is another organization that has really made it their mission to help improve headache treatment in school. Just briefly, there's a few, I'm trying to not take too much time. Some of the new devices that are out there, some others and the devices are helpful in that they're not going to cause systemic side effects. So kids who are really sensitive to medications may benefit from a trial of a device to treat migraine rather than a medication. One we use most often is the Cephally device, which is like a TENS unit for your trigeminal nerve, the supraorbital branch of your trigeminal nerve. It can be used for both prevention and abortive therapy, meaning like if you get used to it, you have to kind of slowly ramp up on the intensity. For prevention, use it 20 minutes a day. For acute therapy, you would put it on for 60 minutes when you have a bad migraine. And it can help with sleep as well. And it's sort of on the border of being affordable. It's about $330. And you can get this without a prescription. It kind of makes your head feel kind of tingly and numb. And some kids really, really like that, and it helps them, and they can use it to abort their migraines. But other folks don't like that sensation as well. But it does have a money-back guarantee you can use. Another one is a gamma core, which is external VNS stimulator. So you stimulate the vagus nerve externally. You can use it again preventatively and abortively. It's less, it's a little bit more expensive, and so we don't use that quite as much. The link for the template for 504 doesn't work. Okay, the links. So Nerivio Migra is another option that is used for abortive treatment right now, but just the paper using it for preventive treatment was just published. So it basically sends a signal that's not noxious, but does stimulate the brain to send down other impulses to inhibit pain signals. And we have a couple kids who have liked this so far. It's about $99 for 12 uses. The new CGRP therapies you'll see everywhere on the computer, on TV. So CGRP is a molecule that is involved in migraine generation as well. So the goal for quite a long time has been to block either the receptor or the molecule. And recently there have been several medications that have come out. The top ones here are about once a month injections or once every 3 months, either injections or IV, that go to block either the receptor for Aimovig or the molecule for Emgality and Ajovy and Vyepti. Then the tablets are molecular CGRP receptor blockers or antagonists. And those, Ubrelvy is approved for acute treatment. Nurtec is approved for both acute and preventive treatment now. And Colepta has been approved relatively recently for preventive treatment in adults. None of these have been approved yet for use in kids, but we are using them in our older teens with intractable migraine with some success. So they are very expensive. I'm just going to turn it over to Dr. Law. Migraine is not your fault. It's genetic.
Heidi and I work together in the multidisciplinary headache clinic in Seattle Children's Hospital, and I hear her give that education to our patients all the time, and it never gets old. I think the take-home message is there are so many things we can try to help these kids feel better. I am going to be talking more about a focus on supporting teens with migraine, and kids, but it's mostly teens that we see in managing migraine at school. I'm going to be sharing common challenges and going through some case examples. So as migraine increases in frequency, every aspect of a child's daily life can be impacted. So often when we're talking about strategies to support a child or teenager with migraine, we need to consider not just managing their migraine symptoms, but also the other areas of their life that are impacted because of how lousy they feel all the time. And I just want to highlight that comorbidities are really common in these kids, particularly insomnia, clinically significant anxiety and depression, and ADHD are the ones we see most common in our clinic. They also have, as migraine becomes more frequent, exponentially increased difficulty pursuing hobbies, spending time with friends, doing their normal routines at home, and especially school is impacted. There's some research showing up to 75% or 3 in 4 youth with chronic migraine, which is migraine at least half the days in the month or more, missed a quarter of school days in an average year. Many have declining grades, despite being really bright kids, and not all of them receive accommodations because of their migraine in school. And if they do get an accommodation, it's typically things like getting to go to the nurse's office, taking fewer classes, or being allowed to rest in the classroom. I wanted to introduce this framework. This is a biopsychosocial framework for understanding migraine and other chronic pain conditions in youth. And what I like about this framework is that it's highlighting not just the teens' migraine frequency or severity of symptoms, but really the interaction between all of these different factors, like Dr. Bloom talked about. Their lifestyle factors can impact how they cope with headache or how they experience it. Also, their mental health, Their genetics, like Dr. Bloom mentioned. And for this talk, I'm focusing specifically more on social factors that are impacted and that get impacted by migraine, and specifically school. There are common goals for school for teens, especially with migraine, and even the younger kids that we see in clinic. Most of them are around just increasing their ability to go to school and stay in school when they don't feel well, to complete homework. So they may be able to make it through a whole school day with a migraine, but then come home and crash and they fall behind in homework. Many of them have this experience where they miss some school either for doctor's appointments or for sick days, and then they kind of fall out of contact with peers, or they may end up transitioning to remote learning instead of in-person learning. So they just lose the sense of belonging to a school community. And so oftentimes goals that get developed for them for school are just part of getting back into the the rhythm of school and feeling good about being there. There are a lot of really challenging things about being in school for kids who have migraine, especially frequent migraine. And it's important, I know you guys probably all know this, but school is really the work of childhood. So if any of you have ever had a migraine and you think about how hard it is to be in your work environment when you have those symptoms, it's just as hard for kids, if not harder. So they're dealing with bright lights, loud noises, crowded hallways, busy cafeterias, demands of things like PE class, challenges around transportation, like some of them get really car sick or symptoms get activated on a bus and they don't have another way to go to school if they don't bus. And I often also hear about just a general lack of privacy or feeling like their migraine makes them different and not wanting to stand out because of their migraine. Social stigma is a really common experience for kids with migraine and other chronic pain conditions because these are conditions that are invisible. There's not a test that we can give to, like a blood test or an X-ray, that can prove or show, their symptoms, and nobody can tell by looking at them that they have symptoms or that they're dealing with a serious medical condition. And because this is an invisible illness, there's new research showing that teens with migraine are more likely to be discriminated against by a whole host of important people in their lives, including us, their medical providers, their peers, people at school, and their family members. And the way this really appears most often is just the experience of being disbelieved that their migraine is not real, not understanding why or how their migraine would impact their ability to participate in things that they usually would love to do. And very commonly is a misperception that their migraine is a psychological problem rather than a physical problem. So a lot of times when we first meet a patient in our clinic, they'll share experiences where they've been told that their migraine is all in their head, or if they just weren't so stressed out, they wouldn't have migraine, or if they just did less screen time, they wouldn't have migraine. All of that is partly true, but it's never the whole picture. And importantly, it's really like when our patients hear these things, it's very invalidating and it is a form of discrimination. So I just want to call that out. Our patients also can have trouble navigating peer relationships, both due to absences, but also there's recent research showing teens with chronic pain conditions, including migraine, are just more likely to be bullied than their healthy peers. And this bullying can happen in face-to-face settings, like on the school, on school grounds, but also a lot of it happens virtually via cyberbullying. And we know that teens who are bullied have an increased risk for a whole host of mental health and physical comorbidities. So it can create this compounding situation where if they have migraine, it's hard for them to go to school. And if they're feeling bullied, they'll tell me things like, well, even if I go, Dr. Law, nobody there likes me, so why even try? Which makes it really hard to help them meet their school goals. There's also this, I was trying to show in this slide, I hope it comes across. There's it's very complicated for teens with migraine to make decisions on how to cope with their migraine in the moment. So they're constantly having to decide, if they wake up with a migraine, whether to go to school or stay home. If they get a migraine during the school day, whether they should try to stick it out or if they should go home. And they get input from many different aspects of their kind of social lives around how to make that decision. And this is, they're just hearing it from everyone, usually. And all of these inputs don't always coordinate or give the same message, which, if you think about just teenage brains in general, are not always really fully developed to be making excellent, like to have ease with decision making. And we're adding a lot of extra burden on them when we're trying to encourage them to go to school and figure out how to do school when they don't feel well. I hear a lot from patients about their experiences in school, and I'm not going to read these out loud, but just want to give a beat for you guys to read them and reflect on them. Just thinking again about, for our kind of treatment philosophy is really that getting our patients back into their daily lives is part of our treatment. It's part of how we heal their pain system. But they're really up against a lot when we're asking them to do that. There are school accommodations, like Dr. Bloom mentioned, which can be helpful for youth with migraine. I saw that, unfortunately, the link to our normal 504 handout isn't working, and we'll see what we can do about that. But in the meantime, if you want to take a screenshot of this, this is like a short summary of the usual kind of basic accommodations that we would recommend for any child with migraine. I would say in my clinical experience, the three that are most helpful are the top three. So having a place to rest during school to give them a chance to cope with their symptoms instead of going home. Having a late start to the school day, especially for teens who aren't sleeping well. And having any strategy like reduced assignments or reduced course load to lower stress and lower burden when they have flares of symptoms. I wanted to touch on 504 plans and individualized education programs, because when we're thinking about the whole social system that's working for and against kids with migraines, these are safeguards that are in place. A lot of you probably know about these already, but for those that are less familiar, these are accommodations or services a child is entitled to receive at school based on their individual needs. To get these accommodations or services, a caregiver or another adult that knows that kid has to request it to the school in writing. Usually requires a letter from a doctor or provider documenting the child's illness and need for accommodations and services. And the one message, if you remember just one thing that I say today, it's that kids with migraine will qualify for a 504 or possibly an IEP because under the category of other health impairment. And I have many kids who have told me that they're told by the school that they don't qualify. And that's just frankly not true. They do. And so it's important to encourage to offer this to kids that you're seeing with migraine and to encourage them and their parents to advocate within their school system so that they can get these accommodations and services. A lot of people ask me what's the difference between a 504 and an IEP. You may have patients asking you this also. A 504 plan is part of the Americans with Disabilities Act of 1979, and it's meant to provide accommodations. So these are things like that I showed you on the earlier slide: extra time to complete work, permission to take rest breaks during the day, permission to have access to snacks or a water bottle. These are accommodations that can be provided to a child with migraine that doesn't require any funding or management. The downside of a 504 plan is there is no mechanism built in to hold the school system accountable to providing the accommodation. So it's really up to the child and the parent to make sure the school is doing what is outlined in the 504 plan. An IEP, on the other hand, is part of the Federal Individuals with Disability Education Act, or IDEA Act. Through an IEP, children receive specific services at school that are paid for by federal funding. And this can be things like specialized instruction, transportation, like they need a bus that comes at 10 a.m. instead of 7 a.m., they can get that bus. Assistive technology, like if it's hard for them to use a computer because the lights are too activating for them, they can get an alternative. It can also be an avenue to get children access to mental health counseling that's paid for through the school district, social skills training, and other types of supports that can help with their overall well-being. An IEP also can allow modifications to curriculum. So things like being asked to just do less when they're not feeling well is something you can get through an IEP that's not always possible in a 504. An IEP includes accountability and regular check-ins from a case manager. So there's automatically a guardrail in place that the districts are legally required to provide to ensure that what's written in the IEP is carried out. Both of them can include similar accommodations, but only the IEP can provide things that cost money. When you're wondering, like, should I tell my patient to get a 504 or an IEP? Most kids with migraine or other chronic illness, if a 504 is a typical starting point, many kids with migraine and other chronic illness will qualify easily with a letter from their doctor describing their condition. 504s also can be implemented quickly. The law says they have to be implemented within 30 days from the time their request in writing comes in. An IEP is more robust. Families can get more services, but the criteria to qualify are strict, and they often take a longer time. So the minimum amount of time to get an IEP is 90 days. But I know for my child who's in Seattle Public Schools, there are kids waiting on IEPs who put in requests 12 months ago. So it can just be a longer process. To get an IEP, it's really worth pursuing for kids who are most likely to qualify, I would say. And so kids who have migraine plus another diagnosis. So if they have a diagnosed learning disability, autism, a diagnosed mental health disorder that the family is willing to disclose to the district, or some other documented need for a modified curriculum, like a history of chronic absences from school is one way you could get an IEP. I wanted to pause and do a little case example. So this is and just thinking about what we've talked about and how it might play out. This is a typical teen we would see in our multidisciplinary headache clinic. 16 years old, white, non-Hispanic, usually a high-achieving student, has had chronic migraine for the past year, has a 504 plan just for migraine. At the start of the school year, she was having migraine, but it didn't impact her. But as her migraine increased in frequency, as stress, like school got more demanding, her schedule got busier, her migraine started to get worse. And by November, we usually see what I call the turkey drop. Kids start dropping from school because it just gets hard. She starts staying home from school because of her migraine. She's late because she can't get herself out of bed. She's missing assignments, and she's going to the school nurse's office every day after lunch because of her migraine. She has a 504 plan, which gives her extra time to complete missing works and tests. So she's implemented that just like we recommended in our clinic. And this helps with some of her classes, but actually increases stress in other classes. And she goes to her teachers and says, can I be excused from any of this missed work? Because there's no way, it's making me too stressed. And she'll hear one thing from one teacher, that's fine, just do what you can. And then other teachers will say, no, I won't do that for you. Other teachers will say it's too late. Other people might say, we can't because you don't have the right kind of accommodation plan. So there's a lot of mixed messaging that comes back. And I see this vicious cycle that develops when a kid goes to people in the school building asking for accommodations, asking for help, and those are not met. They get a no. They'll start to believe that the adults in the building don't believe their migraine is real. They get more distressed. They have more frequent migraine, more frequent missed school, and then they're less and less likely to advocate for what they need to be successful in school. And this cycle just continues and continues. One strategy that can address or disrupt that cycle is really encouraging families to have to build a school-home partnership. And as a provider, you can support that by helping parents and teens articulate what are their goals and expectations for school attendance and homework, helping them articulate what are strategies they're using to cope with symptoms at home that you could maybe try at school. A lot of times, in my experience, families of kids with migraine, they know what works. They just need some help articulating that and really troubleshooting to try a new strategy at school. Sometimes we need to think outside the box too. So I find it's most successful rather than, I see sometimes we see these families that are in such distress that you just want to tell them what to do, like just do online school. Don't even try to go back there. But what's most successful in my experience is really asking the patient, what do they want to do? What are they willing to try? What do they think is going to work? And letting them take a risk and try it out rather than another adult telling them what to do. Being open to being creative is also really helpful if you're hitting roadblocks. Many times I hear there's no quiet place to rest in the school building, but really we almost always can find a place if you're able to find someone in the building who's willing to get creative with you. So I've had kids go to the library. I've had kids where their plan is they found a closet and they were given permission to go to this closet. Or you could build a structure like the photo Dr. Bloom showed. So it's really trying to push the boundaries, not take no for an answer, but find a compromise. And just knowing that small gestures can make a big difference. So there may be times where you don't know how to help a family or we're not sure what to do, but just telling them, I believe in you, I'm on your team. I don't know what to do about this today, but I'm going to keep checking in on you. I'm going to keep seeing you until we figure it out. Because that really addresses, like fights back against this stigma that they may be experiencing. So they know someone who is knowledgeable, who's professional, who has some power, believes them, and is going to be with them, that they're not dealing with all of this alone. This is another example of a kid we're still seeing in our clinic. He's a 12-year-old African-American male. He was diagnosed with ADHD, and this is treated with methylphenidate. His migraine started after his ADHD diagnosis and has become more frequent. He started coming to the school nurse a couple times a week asking to go home because of his migraine. His mom is really worried that his migraine's getting worse and something's been missed. Is it a brain tumor causing the headache? Which makes it hard for her to push him to go to school. And he has a 504 plan for his ADHD, but it doesn't include any accommodations for his migraine. So what would you do? What are your next steps? This is a trick question because there's no right answer. There's many different avenues you could go, all of which would probably help at least a little bit. We can address mom's concern about the brain tumor would be one avenue. We could think about whether the ADHD medication is helping or exacerbating his migraine. Go back to basics. Is he sleeping? Is he eating lunch? Could we recommend updating his 504, or would he qualify for an IEP so that there's migraine accommodations accessible to him? Has anybody talked to his parents about goals for school attendance? And what are strategies that he's willing to try to support symptom management at school? Does he have his rescue medications at school? What is he willing to try on his own where possible? Any one of those things would at least help him feel seen, heard, and motivated to manage on his own a little bit more. So in summary, migraine is what you've heard from both myself and Dr. Bloom. This afternoon, migraine is really common in childhood. As frequency of migraine increases, so does the impact on school and other aspects of daily life. Co-occurring conditions are very common. These kids are eligible for special accommodation plans at school that are protected under state and federal law under the category of other health impairment. And nurses really are like magic for these youth to help them feel seen, valued, and reach their school and broader life goals. And I just wanted to we hear a lot of compliments about nurses from our patients too. And so I wanted to share some of these with you all as well. I just want to end by saying thank you. Dr. Bloom mentioned I have a number of research studies going in the area of improving access to evidence-based treatments for kids with migraine. I'm really hoping, I'm working right now on developing a community advisory board that would include nurses, representation of nurses from community pediatrician offices, from schools, and please reach out to me if you think you might be interested in participating in that effort. I want to be developing treatments that have reach, that are relevant for you guys too. And so I need to hear from you. So please reach out. And we'd love to take some questions.
Perfect. Let me share my screen so that you can also see the questions that have been coming in during your talk. The first one is, do kids with migraine outgrow them, or do they tend to experience them as adults as well?
That it depends. So some kids will outgrow them and just have a time in their lives. Sometimes even it's in the young elementary school age kids where they have them when they're younger and then not when they're older. In the school age kids, boys are a little bit more likely to have headaches and migraines than girls. It's about 50-50 though. And the boys, I always tell the boys that they're more likely to grow. Boys tend to be more likely to grow out of their migraines after they hit puberty, or maybe when their growth spurt is over. There's not a lot of data on that. That's just what we see. Unfortunately, for better or for worse, females are more likely to grow into their migraines and have them start when they're in their teens or 20s. But my personal experience, I always use my family as an example because a lot of us have had migraines. So I got to be in bed, miss stuff, and puke a couple times when I was in middle school, and then they got a lot better. And they still were, popped up occasionally. My youngest son had started having migraines when he was 4, and now he's 16 and has them. He really grew out of them really last time he threw up, he was really young. So it can vary. There's not one path, though. I do some of my complicated male patients. I'm just sort of really hoping if we can just get them through to their growth chart, to their height kind of plateauing out, they often will feel better at that point. And I have another female patient though right now who's now 16, just saw her the other day, and 16, and her symptoms are improving, and her mother's symptoms improved around the same time in her life as well. So there's probably hundreds, if not thousands, of different genetic changes that all end up with migraine, and so everybody's a little bit different. So
that's really helpful to know. Thank you. And then here's another question: are some of the newer migraine drugs coming out going to be available to children, like Ubrelvy?
Yep. So certainly we hope so. They are doing trials. We are involved with trials for Emgality and lasmiditan, and hope to be involved with Nurtec in the next year or in the coming months. However, I'm still prescribing them off-label for our older teams with intractable migraines, and there is some data from clinics, sort of retrospective data, looking at not the what we call the GPANTs, Ubrelvy. They all end up with the last part of these names are GPANTs, Ubrelvy, Pant, and Rimegepant. There's less data on those for kids yet, but people are using them, and we found them anecdotally to be helpful for some kids. But overall, all the new medicines seem to be about a third do quite well with them, a third have some improvement, and a third they don't seem to really be that helpful. So yes, the studies are ongoing, and yes, we can sometimes get them approved for teenagers, but it's a challenge, and you need to have there's potential side effects since they really haven't been FDA approved yet for kids. So I try and wait till the kids are at least past their growth spurt or in late puberty before trying them if possible.
Thank you. And then you said to not use Fioricet. Is that just for pediatrics? They're thinking it was effective in adults.
Well, I know that a lot of people my age, and maybe even a little bit younger, use Fioricet and say that's the only thing that really helped their migraines. I think most headache specialists will try not to use Furoset these days, just because of the risks of rebound, risks of potential addiction, and that, well, at least for the opiates, we know that even if you just use it short term, it can actually change how the receptors populate the cell membranes. So it can be effective for some people, and I know there's people who use it and use it successfully and don't overuse it, and it's really a miracle, or if they feel like it's the only thing that works for them. But hopefully those medicines will be used less and less as we get more targeted medications that are really aimed at stopping the migraine cascade. There are some neurologists probably who prescribe Furoset. I know there are, so but guidelines are recommending against it. Long-term side effects for topiramate. So there's always potential side effects for a lot of these medications. Once you stop the topiramate, we don't think there's going to be long-term complications. So some of the things for topiramate are decreased appetite, kidney stones. Kidney stones is rare and would be extremely rare in the low doses we're using for migraine, unless you're on other medications. Mood changes are, as you know, are potential side effects for any medication pretty much that affects the brain. But once you stop the medicine, those effects go away. So the side effects are really going to be more like when you're on them for a long term. The whole bone, it is an anti-epileptic medication, so there's the whole question about bone density. But again, the doses we're using for migraine are low, and we try I didn't go over all the guidelines, but the guidelines do recommend that once migraines or headaches are under better control, then we try and taper off of the preventative medications. And also, topiramate, the big thing for our teenage girls is that it can decrease the efficacy of oral contraceptives. So it's something you need to just think about.
Thank you. And this is our last question. We were told by a school representative that you could have a migraine syndrome without having headaches. For example, frequent stomach aches. Can you speak about this?
Yep. It's always so that you can have abdominal migraines. There's enough there, again, challenges with what is causing stomach pain. Is it an abdominal migraine, or is it a functional stomach disorder, or is it IBD or something else? If we could get Kassan back on here, that might be good. So yes, there are other syndromes that are accompanied by migraine that can maybe fit under the umbrella of a migraine syndrome where you don't have headaches. Some people, it's not as common, and the abdominal pain issues are often more in younger kids, then kind of evolve into headaches as they get older. So that's true. And migraines at school, also for the 504 issue, which people may have seen on the chat, they do have some examples of 504 plan. There is some examples of 504 plans after the final slide. I have extra slides after that genetic migraine slide that outline some of the things we put on. And here we have it in Epic now. This is some of them. This is the 504. So these are some of the options.
Thank you for your presentation and answering all the questions. It's very helpful, and it sounds like there's still a lot of advocacy that we can do as school nurses to make sure that students are getting what they need and their 504s are being followed so that they can be supported at school.